Sometimes it's a matter of fine judgment when to use endotracheal intubation, but here are some strict guidelines for its prudent use. Patients rarely die from failure to intubate. They die from failure to adequately ventilate. Profound hypoxemia is always treated first with manual ventilation, that is, mask ventilation. If a patient is severely hypoxemic, the treatment is bag valve mask ventilation first. You do not go straight to endotracheal intubation. That is just wrong. Proceed to endotracheal intubation only after the hypoxemia has been treated. Only then proceed to attempts at endotracheal intubation if the patient is truly unventilatable. If bag valve mask ventilation fails, say the patient has severe asthma or it's a true cannot ventilate scenario, only then do we proceed to intubate a hypoxemic patient. Of course, we can try to ventilate with an LMA. We need to do our utmost to avoid wasting time on intubation when the patient needs ventilation. We can now proceed to the mechanics of intubation. First, however, we will extend the patient's head on the neck, but only if it is safe to do so. In some patients, such as those with head and neck trauma or severe cervical spondylosis, it is most definitely not appropriate to move the neck at all. So the following only refers to patients with normal cervical vertebrae. Now, I teach laryngoscopy as a two-step process in the adult patient. These images show the mannequin head in a normal anatomical position. The long axis of the mouth is shown in red, and the long axis of the trachea is shown in black. And the two are nearly, but not quite, at right angles to each other. And this explains why, when we look into a patient's mouth in this position, it's simply impossible to see the larynx, and hence the need for a laryngoscope. Once again, the battle is fought and won in the preparation. Head position is critical, and blade position in the mouth is critical. Starting with our patient's head in the neutral position, we can improve our chances of successful laryngoscopy as follows. We are going to elevate the head slightly by placing the patient's occiput on a headrest such as a gel support or a towel or a pillow, and this flexes the cervical spine a little. That is, it moves the cervical spine anteriorly. Now recall that in the previous presentation on manual ventilation, we used a series of maneuvers to open the airway so that gas could flow from the patient's mouth into their lungs. These maneuvers will successfully open the airway enough for gas to flow down the airway. So let's think about this. Maybe these same maneuvers will be successful in opening the airway enough for us to actually see down the airway and visualize the larynx when we perform laryngoscopy. The first maneuver then will be the chin lift maneuver. The second is head extension, and immediately prior to intubation, experienced providers often do these two maneuvers simultaneously, with the left hand lifting the chin and the right hand positioning the occiput. This maneuver generates extension at the atlanto-occipital joint between the base of the skull and the cervical vertebrae, so that the head is extended on a slightly flexed neck. Traditionally, anesthesia providers have described this important position as the sniffing the morning air position. And more details of these maneuvers are going to be shown in the following videos. When the chin lift and head extension maneuvers are performed properly, we see the oral and laryngeal axes coming more into line. They become collinear. They are not quite lined up, but they're getting closer. Now, back to our airway maneuvers. Remember that during mask ventilation, the final maneuver was the jaw thrust? Well, we're not going to do a jaw thrust, but we're going to do something very like it. Instead of using external pressure on the mandible to push the jaw upwards towards the ceiling, we will use the curved blade of the laryngoscope to lift the mandible up towards the ceiling from the inside of the airway. At this point, some intubators will attempt to pry the mouth further open to facilitate insertion of the laryngoscope blade by a technique called scissoring, where finger and thumb push on the right side of the upper and lower teeth, that is the teeth in the upper and lower jaw on the right side of the mouth. But I have to tell you, I discourage this, and I solicit caution if the intubator must do this. The correct application of the first and second airway maneuvers nearly always causes the mouth to pop open enough for insertion of the tip of the laryngoscope blade. The success of this technique is predicated on proper positioning of the laryngoscope blade on the right side of the mouth. The laryngoscope blade must be placed on the extreme right side of the mouth, very close to the right-sided molar teeth. Normally, the right side of the tongue touches the molar teeth when it's sitting in the mouth, but we will use the blade to displace the patient's tongue leftwards, and this opens up a space which exists between the right side of the tongue and the inner or medial surface of the right-sided molar teeth, and I call this the paralingual gutter. A normal, healthy tongue is very floppy, and it's easy to displace in this manner using the vertical bar that is part of the design of the Macintosh blade. This is important. The Macintosh blade does not sit on the tongue and compress the tongue. It displaces the tongue leftwards. Now, consider this. The front of the mouth at the teeth is very wide, but at the level of the larynx, the airway has narrowed a lot. So when we insert the laryngoscope blade on the right side of the mouth, as we advance it, the blade will naturally move towards the midline, eventually reaching the vallecula, which is a midline structure. The vallecula is a little space directly above the epiglottis, and the ideal position for the blade is shown in the radiological scans on your screen. These images show the tip of the blade in the tip of the Macintosh blade in the vallecula. But note that when using a straight blade such as the Miller blade, the tip of the blade does not go into the vallecula, it goes under the epiglottis and it lifts from beneath. And of course, the terms above and below epiglottis are required to the patient being in the supine position. The next essential part is this. Most learners insert the blade way too far. Now, to prevent this, the Macintosh blade is inserted only 2/3 of its length, and then you will lift the laryngoscope handle diagonally upwards. This is the first lift of the laryngoscope handle in a two-lift technique. The direction of lift of the laryngoscope handle will be upwards to where the wall of the operating room meets the ceiling of the operating room, and this motion elevates the tongue and the patient's mandible in a fashion exactly analogous to the jaw thrust. This is just like doing a jaw thrust internally rather than using pressure on the mandible externally to lift the mandible. So, as the first lift is performed, you look at the anatomy for any recognizable landmarks, and in this case, what you almost always see is the tip of the epiglottis. When you see the tip of the epiglottis, it's telling you, hey, you're in the right neighborhood. You're very close. Just keep going in this direction. So, at this point, you relax tension on the laryngoscope blade. Then you advance another ½ inch for short patients and up to a full inch for taller patients. And the tip of the laryngoscope blade will be in, or at least very near to the vallecula. When you lift the laryngoscope blade a second time in exactly the same direction as before, that is, diagonally upwards to where the wall meets the ceiling, in the large majority of cases, the epiglottis is going to elevate and it will reveal the true vocal cords with the glottic opening sitting between the true vocal cords. At this point, the oral axis, shown in red, and the tracheal axis, shown in black, will be almost collinear, a straight line. So you should have a very reasonable view of the larynx and a straight path to the larynx. Now, to intubate it is often a simple matter of advancing the endotracheal tube through along a straight line down the airway, through the glottic opening, past the vocal cords, and into the trachea. You pick up the endotracheal tube at its midpoint and pass the tip of the endotracheal tube along this corridor that you have created on the right side of the patient's mouth, all the way to the glottic opening. In the majority of cases, the tip of the endotracheal tube will pass easily through the glottic opening and into the trachea, and our aim is to stop advancing when we envisage in our mind's eye that the tip of the endotracheal tube is probably close to the mid-tracheal point. And the guidelines earlier, 23 centimetres at the incisor teeth for a man and 21 for a woman, are very helpful. Now, there are very tall women and there are very short men, so we use these approximations. When the 21 centimetre calibration reaches the lower incisor teeth in most females and approximately 23 centimetres at the lower incisor teeth in most males, we should be at mid-tracheal point. A 10 ml syringe is attached to the pilot balloon and is used to inflate the cuff of the endotracheal tube. The tension in the cuff will be the same as the tension in the pilot balloon, and we can measure this tension if we need to. The endotracheal tube is then connected to the breathing circuit, and the adjustable pressure release valve is adjusted to a pressure of about 20 centimetres of water, and the reservoir bag is squeezed while looking for bilateral symmetrical chest excursion. The reservoir bag is squeezed a couple more times while the lungs are auscultated, high in the left axilla, then high in the right axilla, because these positions will allow you to listen to all lobes of the lung. We want to confirm bilateral symmetrical breath sounds. Sometimes, when we use video laryngoscopy, it is difficult. We get a good view of the larynx, but it is difficult to advance the tube. And the manufacturers of the GlideScope provide a special GlideScope stylet, which allows you to maneuver the tip of the endotracheal tube around the corner. The point here is that an excellent view of the larynx doesn't always mean easy intubation. With conventional direct laryngoscopy using a Macintosh and Ramilla blade, if you can see the glottic opening, you can nearly always get the endotracheal tube to pass through the glottis. But with video laryngoscopy, such as a GlideScope, it is common to get an excellent view of the larynx, but have difficulties in advancing the tip of the tube to the glottic opening. In this situation, the use of an endotracheal tube stylet will allow the shape of the tube to be preformed, giving it a tighter curvature, or sometimes perhaps even a hockey stick shape, in order to assist passing the tip of the endotracheal tube through the glottis. Again, while this does happen with conventional laryngoscopy, it is particularly challenging with video laryngoscopy, and either a generic stylet or the specialized GlideScope stylet will be necessary to successfully deliver the endotracheal tube around the corner to the glottic opening. Keep in mind, however, that most difficulties with laryngoscopy and advancement of the tube will remain attributable to poor patient head position or poor blade position in the mouth. And both of these, if these occur, both of these are essentially failures of the intubator's technique. Difficulties with either laryngoscopy or advancement of the endotracheal tube should lead to a re-evaluation of the patient's head position and a re-evaluation of the blade position before we blame it on the patient's anatomy. It is true, however, that up to 3% of all our patients will have challenging or difficult laryngoscopy, as defined by the inability to obtain a laryngoscopic view better than a grade 3 or 4 Cormack and Lehane glottic view. And up to 6% of our patients will require 3 or more advancements of the endotracheal tube to intubate successfully. So I want to emphasize, there are 2 procedures going on here. There's getting a view of the larynx, which we call laryngoscopy. The second procedure is advancing an endotracheal tube successfully through the glottis into the trachea. So in summary again, extend the head on the neck if it's safe to do so and the mouth pops open. Place the tip of the laryngoscope blade into the right paralingual gutter, displacing the tongue to the left. Advance the laryngoscope blade 2/3 of its length and then perform the first lift, directing the laryngoscope handle diagonally upwards towards the ceiling meets the wall. This 2-left technique is predicated on the fact that many learners insert the blade too far the first time. You will see the tip of the epiglottis, then relax tension on the laryngoscope handle and carefully advance another half an inch or 1 inch depending on the size of the patient and lift diagonally upwards a second time. The second lift allows the epiglottis to be elevated and reveals the true vocal cords. When you have a good view of the glottis, advance the endotracheal tube along the corridor you have created on the right side of the patient's airway, pass the tip of the tube through the glottis, and we aim to place the tip of the ET tube at the mid-tracheal point by advancing it until the 23 cm mark or the 21 cm calibration marks are level with the lower incisor teeth in men and women respectively. Thank you so much for watching this presentation. Remember, the battle is fought and won in the preparation. And also remember, this is a real truism. In anaesthesia, knowledge is power. I hope this helps you in your endeavours to master the essential airway skill of endotracheal intubation. Thank you.